Hello, good evening, all our esteemed friends from who are joining us from Maharashtra Ophthalmological Society, and also those who are joining us across the country, especially all our young stars, all our young residents who look forward to this webinar every fortnight to take not only academic but also a lot of practical pulse from our both national and the state faculty. We have been lucky to have overwhelming response. And this year, as you all know, this year we have had 1 month which is designated to one specialty. And this month's specialty is actually one of the most interesting specialties, which is uveitis. All of us as residents and postgraduates probably have very limited access to uveitis patients. And in most of the medical colleges, they don't have a uveitis department as such. So today we are very lucky to have our faculty who is very well renowned nationally and internationally in the specialty of uveitis. They are going to take us through the practical pulse and also teach our postgraduates common questions which are asked and how to answer them as well, so that all of you are very well prepared. Uh, of course, now I would like to first thank all our year-long coordinator, Dr. Sumit, who has been instrumental in making this PG programs a huge success month after month. So thank you so much, Sumit, for all your hard work. And we would like to welcome our national faculty, Dr. Samyava Basu, who is from LV Prasad Eye Institute, and Dr. Mayur Morekar, who is our state faculty. Both of them are going to enlighten us. And today we have Dr. Rohit Modi, who is going to be our chief moderator, who will be taking us through and making sure that today's webinar is very interactive and full of pulse. So first of all, I would like to now invite our Honorable President, Dr. Santosh Agarwal, sir, to kindly give his welcome address. Over to you, sir.
Thank you, Dr. Vardhaman. Respected seniors, teachers, my dear colleagues and PG friends. Good evening to everyone. At the outset, I thank Dr. Sumit, Dr. Vardhaman, Aditi and MOS Scientific Committee for crafting these PG webinars on behalf of MOS. I am also grateful to today's mentor, Dr. Prajakta More, panelists Dr. Basu, Dr. Mayur Morekar, moderator Dr. Rohit Modi, and our case presenters, PGs, Dr. Maxwell from BJMC Pune and Dr. Srushti Kolte from Kashibai Navle Medical College, Pune, for taking out their valuable time to enlighten all of us. As you are aware of this type of PG activity, always impart the opportunity to present the cases by PGs, which eventually boost the confidence of them to present them in their practical exam as well. Moreover, the question answer session and panel discussion would definitely help all of us to update our knowledge as well. I wish all the very best to our today's case presenters and looking forward to many more such PG activities in near future. I appeal all PGs to take part in such activities and also don't hesitate to ask your queries to our experts. Thank you for giving me this opportunity to interact with you. Today's my quote is, if you believe in yourself, anything is possible. And second is, he who studies medicine without books sails an uncharted sea. But he who studies medicine without patients does not go to sea at all. Thank you very much for giving me this opportunity. Thank you. Over to Vardhaman, please. You are muted, Vardhaman.
Thank you so much, sir. As always, very enlightening quotes, and thank you for encouraging all the postgraduates. Without further ado, I would like to now hand over the course to Dr. Prajakta ma'am, who is the mentor for today, Dr. Rohit, who is the moderator, and Dr. Sumit. Over to you.
Thank you so much, sir. Thank you, whole MOS team, for giving this platform to all the PGs. And we are covering all the postgraduates from all over the state, from government medical colleges, and they are very happy that they are having this platform to. their questions, queries are getting sorted here. So today for the uveitis, our main presenters are Dr. Srushti Kolte and Dr. Maxwell from BJ Medical College and Kashibai Navale Medical College. So they will be presenting their respective cases. We have our mentor for today, Dr. Prajakta ma'am. She is assistant professor at BJ Medical College. Thank you, Prajakta ma'am, for mentoring and giving this platform and cases to the kids. And
Thank you,
Dr.
sir.
Rohit, my dear friend, is moderating the whole show. Rohit is a very good clinician. He's the ex-secretary of BOA and someone to look forward to. And he graciously agreed on a single message to moderate this thing. And last 3 days, he's constantly taking dry run for the PGs for their preparation. Thank you, Rohit, for all your efforts and being here. I will hand over to Dr. Rohit for the going ahead, and Dr. Srushti will start her case. Rohit.
Thank you, Sumit, for this wonderful opportunity. And it is always great to be a part of a uveitis, webinar, my favorite subject. And I have the pleasure to introduce my guru, my mentor, Dr. Somaya Basu sir. He is the network head of uveitis services of entire LV Prasad Eye Institute. He's done a path-breaking work in ocular tuberculosis, and a lot of unanswered questions were answered by his research, and it is his continuous endeavor to keep doing so. He inspires and teaches a whole generation of, he has done that to a whole generation of uveitis specialists. There are at least 4 or 5 of his students who are practicing in Maharashtra, especially Mumbai. And Dr. Mayur Moreka sir, our own beloved, local faculty, he doesn't require any introduction. He is an associate prof at Bombay Hospital, and he has done focused work in ocular inflammation and uveitis. And he's our go-to person whenever we face any challenging uveitis patients in Mumbai. So it is great to have you both, sir. I'll request Dr. Srushti to present her case.
Good evening. Today I'm presenting a case on post-Schlossman syndrome. This was a 33-year-old male patient. Just a minute. Just a minute.
The slides are visible. You can go.
Okay. There's a 33-year-old male patient who had, just a minute, I cannot see the slide. Sorry, just a minute. 33-year-old male patient came to the ophthalmology OPD with complaint of pain in right eye. Pain in the right eye for 4 days. The pain was acute in onset.
Srushti, wait. Go to that slide. Select the slide. Second.
Yeah.
Next slide. Yeah. Now
Yeah.
go ahead.
33-year-old male came to the ophthalmology OPD with complaint of right eye pain since 4 days. The pain was acute in onset since 4 days, dull aching type behind the eye. There were no aggravating or relieving factors. There was history of blurred vision since 4 days and light sensitivity. There was no history of ocular trauma, floaters, flashes, curtains, and similar symptoms in the left eye. Past history, the past ocular history, patient gives history of similar episodes 2 times previously in the last 2 years. Patient visited the ophthalmologist for the same, the details for which are not available. There is no history of ocular surgery. Medical history, no history of tuberculosis or tuberculosis contact. No history of fever, chills, fatigue, weight loss. No history of skin rashes, sores, white patches, loss of hair. No history of joint pains or lower back pain, deafness or tinnitus. No history of recurrent URTI or cough. No history of pets at home. No history of allergies. No family history of glaucoma. General examination was within normal limits. Ocular examination, facial symmetry was present. Head posture was normal. Both eyes normal position. Vision vision of the right eye best corrected 612 with pinhole 69. In left eye best corrected vision was 6.6. Near vision was N6 in both eyes. I will describe the right eye findings first, followed by the left eye. The lids were normal. Conjunctiva showed mild conjunctival congestion. Cornea on slit lamp examination showed keratic precipitates, which were 10 to 15 in number. Size small, round, white, flat lesions, non-pigmented, discrete deposits with round edges, distributed inferiorly on the back of the corneal endothelium in a base-down triangle pattern, suggestive of fresh non-granulomatous capies. This was associated with minimal stromal edema. Anterior chamber on examination with the size of slit lamp beam 1 into 1 square millimeter, maximum illumination, 16x magnification and 45 degrees orientation of the beam. It showed around 5 to 6 cells per field corresponding to occasional cells according to Sun classification. The pupil was normal size, sluggishly reacting to light. Lens was clear. Intraocular pressure on applanation tonometry was 40. Extraocular movements were fully freely in all gazes. Left eye slit lamp examination was within normal limits. Intraocular pressure on applanation tonometry was 16. Extraocular movements were fully freely present in all gazes. Visual fields on color vision were normal in both eyes. Dilated fundus examination of both eyes showed clear media with normal sized optic disc, CDR 0.4, FR plus, blood vessels normal, periphery within normal limits. These are my differential diagnoses. Viral anterior uveitis, Fuchs heterochromic iridocyclitis, pigment dispersion syndrome, Post-Schlossman syndrome. Thank you.
Nice case, Rushti.
Thank you, ma'am.
Okay, so you have said that there were fine KPs and cells. So that was suggestive of an acute anterior uveitis, right?
Yes.
So what could be the DDs of acute anterior uveitis? Can you enumerate some?
Yes, it can be arthritis-associated uveitis like HLA-B27 uveitis, reactive uveitis, or psoriatic uveitis. Then it can be viral anterior uveitis like HSV, VZV, or CMV uveitis. It can be Fuchs heterochromic iridocyclitis, and it can be Post-Schlossman syndrome.
Okay. So you said about ankylosing spondylitis also. So can you tell me some of the key features of ankylosing spondylitis associated uveitis?
They have a small discrete KPs and there is more reaction. 2 to 4 plus reaction can be present. Intraocular pressure can be low or high depending on the cycle.
Okay.
And
Can you name? Okay. You were saying something.
Srishti,
What are the...
stop sharing me. Sorry, ma'am. Just stop sharing.
Yeah. Okay.
Yes, ma'am. Continue.
Okay, so what are the other systemic features of ankylosing spondylitis so that you come to a, say, depending on history or something to that findings?
There is history of joint pain, lower back pain, question mark posture is seen.
Okay, good. You also mentioned about viral uveitis, right? So can you tell me some specific findings of viral anterior uveitis, acute anterior uveitis?
There are again keratic precipitates and anterior chamber reaction in herpetic uveitis. It is more. And in CMV anterior uveitis, there is minimal anterior chamber reaction. Ma'am, you are not audible.
Hello?
Yeah.
Can you hear me?
Yeah.
The Posner is associated with which viral uveitis? Most
CMV uveitis most commonly.
Okay, very good. You've given Fuchs in your differential diagnosis, right?
Yeah.
So how will you differentiate that from your Posner syndrome?
Fuchs has stellate diffuse KPs present. Then it has more reaction. And on gonioscopy, there is presence of blood vessels which are crossing the angle. In Fuchs, in Posner-Schlossman, there is small discrete KPs which are present usually in the arch triangle, and there is minimal anterior chamber reaction, and angles on gonioscopy are open.
Good. So we can go ahead with any other questions, or we can go ahead with the next case.
Yeah,
Hello?
we can go ahead with the next case.
Rohit,
Yeah.
I think we can do a panel discussion with them right now
Sure,
to
sure.
complete the whole
Definitely.
case.
Absolutely, absolutely. I would invite Dr. Somaya Basu sir and Mayur sir for the panel discussion. Sir, what would be your inputs for Dr. Srushti for management of the presented case?
Mayur will go first.
Okay. So Shrishti, very well presented case, and you have highlighted the four most probable differentials very well. And I would believe that you would understand that the most probable diagnosis here is Posner-Schwarzman syndrome. So, for from a general ophthalmologist point of view, or even from a uveitis specialist point of view, it is extremely important that we come first to the clinical diagnosis. So in this case, you have put a few differentials like viral anterior uveitis, you have put Fuchs heterochromic iridocyclitis and Posner-Schwarzman syndrome. So very unlikely that this is Fuchs, because you've not described the iris hypochromia. There's no posterior subcapsular cataract. Between the two, viral anterior uveitis and Posner-Schwarzman syndrome, the fact that there has been an acute rise in IOP 2 or 3 times, and the fact that you are dealing with a pressure of around 40 makes one feel more in favor of Posner-Schwarzman syndrome. If one still wants to entertain the diagnosis of viral anterior uveitis, then obviously one thinks of CMV as the virus. From the point of view of diagnosis, I think a clinical diagnosis is enough for such cases. One may think of any further investigation in terms of something like a PCR or something, but I think that would be an overkill. The diagnosis is mostly clinical. One in such cases just requires to control the intraocular pressure and to also control the inflammation. Since the inflammation is minimal, it requires 2 or 3 drops of Redfort in a day, and the intraocular pressure would require topical anti-glaucoma. Most times we achieve a control of the pressures and the inflammation in a few days, and then it may be pertinent to try to taper off and stop the treatment. And I think that's a pretty clear cut. Basu, you have something to add?
Yeah. Thanks, Mayur, for your inputs. No, I'll start off from the beginning, and that would be about whether to call this granulomatous or non-granulomatous uveitis. You clearly described that there were KPs and they were there in the Arls triangle. When you describe KPs, these are deposits on the endothelium with a volume. These are not mere endothelial dusting. That distinction needs to be made very clearly. And if you have distinguished those deposits on the endothelium from just dusting, then your HLA-B27 or ankylosing spondylosis associated uveitis goes out of the picture. Because remember that B27 is positive in about 5 to 6% of the normal population. So in such a patient, if you test for B27, there is that chance that it may still come out to be positive and you may get misguided. So B27 goes out of the picture. And also the other point is, at presentation, if the patient has never been started on steroids in an acute uveitis, B27 can have a low IOP. High IOP without any steroids in a B27, in a anti-uveitis patient rules out B27. So that can be excluded from the differential diagnosis. Now, what all do you have with you? You have KPs in the Arls triangle, which I assume are non-pigmented KPs, and you have an intraocular pressure of 40, and you have a patient who came with a history of pain. I think that pain part is very critical, but the redness part was mild. I think you mentioned that there was just mild conjunctival congestion. So there are points in favor and against all the differentials that you mentioned. Okay, if we start with Fuchs uveitis syndrome, which Dr. Mayur just mentioned. So Fuchs will have the KPs over the horizontal midline. And once you see those diffuse KPs above the horizontal midline, then only you start thinking of Fuchs. Here, the KPs are in the Arls triangle. So Fuchs goes out of the picture. Of course, you don't have the posterior subcapsular cataract and the membranous vitritis that you typically see in a Fuchs patient. Remember, Fuchs is most commonly misdiagnosed as intermediate uveitis. So that thing should be there in the background. So Fuchs also goes out of the picture. The main difference that you want to make here is between Posner-Schlossman syndrome, which has been mainly associated with cytomegalovirus, versus herpes simplex or herpes zoster virus induced anterior uveitis. So HSV VZV on one side and CMV on the other side. Now, what are the points in favor of CMV? The points in favor of CMV are that the IOP is quite high, 40, and the patient only had mild congestion. Okay, so these points are in favor of CMV. If you had done a specular microscopy in this patient, you would have seen a low endothelial cell count. That would have also supported your diagnosis of CMV. However, KPs in the Arls triangle, while not impossible in CMV, are less likely. The KPs in CMV are more often central. So here I am a little more tempted towards HSV or VZV. And this distinction is important because both of them require different antiviral agents, as you understand. Okay, so for HSV, VZV, the key is in the pigment. So your KPs have to be pigmented. You need to have pigment dispersion in the antechamber, and you will have loss of pigment from the iris. Now, sometimes it's not very obvious. You might see pictures in the textbook showing sectoral iris atrophy, which is very, many times it's not so obvious. You may just see a patchy iris atrophy. And the best way to find that out is to do a retroillumination, where you will be able to make out the iris atrophy much better. Sometimes even that is not very well seen, but you will see that the pupil is D-shaped because there is atrophy of the sphincter pupillae at one edge. Therefore, the pupil is D-shaped, and that will tell you that you're probably dealing with HSV or VZV anterior uveitis. The last thing you can do is check for corneal sensation, and loss of corneal sensation will also tell you that you're probably dealing with HSV or VZV. The question remains open which of the viruses it is. Probably a deeper evaluation will tell you, and it need not require a PCR. I think PCR is quite secondary here. Will tell you, a more detailed evaluation will tell you whether it's CMV or it is HSV, VZV, and you treat accordingly. Okay.
Yes.
Thank you, sir. That was quite enlightening. how long should we continue antivirals in a patient with viral anterior uveitis?
I'll take that. Yeah. So usually I treat for 3 months, but I always give example of this one patient that I started treating in 2009, and he was a one-eyed patient. The other eye was already lost to end-stage glaucoma. So in that one eye, every time I would stop the antiviral, it was just 500 milligrams twice daily of valaciclovir. And every time I would stop the antiviral, his IOP would shoot up and he would come back with a recurrent anti-uveitis. So I kept treating him with that 500 BD and sometimes 500 TDS of antiviral from 2009 till end of 2019 when I probably last saw him. So that could also be the case. Remember, these viruses, once they are in the body, they are there in the body for life. Whether you treat for 3 months or for 3 years or 30 years, they are there for life. So there is no, one specific duration that you have to treat this patient for.
Thank you, sir. Mayur sir, your take?
I think I would have a very similar take. Only the drug may change when I go to the maintenance phase. I shift to ACD 400 milligram twice a day. And the duration would be almost, like what Dr. Basu said. We've had instances where we've tried to stop and then had relapses. So in many patients, the duration is much longer than what would be described. But I think I would go at least 6 weeks in most patients before I try to uh, attempt to stop the antiviral.
Thank you. Thank you. Santosh sir, would you like to add something?
Yeah, one thing I want to tell to the PGs that whenever they are asked about any differential diagnosis or any etiological or causes, they should come out with common causes first. Okay, one thing. And second thing is whenever you are giving the history, no history of this, no history of this, no history of this, then you should know the causes of that every condition or that history is evaluated in that condition. So that is very important because examiner can ask you in which condition you will see you will evaluate this history. So that two things I want to just tell. Okay, thank you.
Thank you. Now I would like to invite Dr. Maxwell Silva to present his case.
Hello, am I audible?
Your voice is breaking a bit.
Dr. Maxwell, can you hear us?
Am I audible now?
You are audible, yeah. Can you
Yeah, I
share
can
your
hear. Am I
screen?
audible?
Yes, yes, you are audible.
Yeah, I'll share. Okay. Before starting, I would like to very good evening, everyone. Myself, Dr. Maxwell Silva, junior resident from BJ Government Medical College. So before beginning my case, I would like to thank all the MOS committee members for giving us opportunity and platform for such kind of interactive case discussion. And so I'll be sharing my screen. Is my screen visible?
Yes, you're audible and your screen is visible. Please go ahead.
I'll begin my case. A 45-year-old woman presented to the outpatient department with a chief complaint of diminution of vision in both eyes since 2 months. So patient was apparently ordered 2 months back when she noticed diminution of vision in both eyes with an episode of acute pain for which patient took over-the-counter pain reliever. Patient also had history of cough and breathlessness since 1 year. No history of specs use, no history of ocular surgery, no history of any ocular trauma, no history of weight loss or fever, no history of stiffness of joint pain and backache. There was no history of recurrent mouth ulcers or any skin lesion. There was no history of nausea, vomiting, no history of any hearing loss, tinnitus, neck stiffness, or whitening of eyelashes. There was no similar complaints in past. So personal history was within normal limits. Family history was not significant. General examination was within normal limits with vital stable. Systemic examination was also within normal limits. Ocular examination, facial symmetry maintained, head posture normal, ocular position normal in both eyes, extraocular movements full, free, and painless in all gazes for both eyes. So move on to the examination, ocular examination. In best corrected visual acuity, in right eye was finger counting 1 meter, and in left eye it was counting finger close to face with PL positive, PR accurate. Intraocular pressure on appellation tonometer at 10 am was in right eye was 16, and in left eye it was 14. Lead adnexa in both eyes was within normal limits. Conjunctiva in both eyes there was conjunctival congestion present. Cornea, both eyes they were normal size. There were molten fat keratic precipitates present inferiorly. The anterior chamber for both eyes it was shallow with Van Harry grade 2 and anterior chamber cells 2 plus. Iris in both eyes normal pattern and color. Pupil both eyes was irregular, sluggishly reacting to right. And in right eye the posterior synechiae present at 1, 2, 4, 7 and 9 o'clock. And in left eye they were at 5, 7, 9, and 12 o'clock. There were festoon pupillar dilatation in both eyes. Lens, both eyes, there were nucleus sclerosis grade 2 with iris pigment dispersed on lens. Fundus examination, both eyes were within normal limits. So, based on the basis of clinical findings, we came to provisional diagnosis of both eyes granulomatous uveitis with complicated cataract. So, patient was studied on eye drop prednisolone 1% 1 hourly and eye drop home atropine 2% 3 times a day. And simultaneously, patient was referred to chest physician because she had complained of also chest breathlessness and cough. So they investigated and they found the CB-net sputum was positive. So in coordination, we decided with chest physician to start anti-tuberculosis treatment for this patient. And this was a 1 month follow-up. The granulomatous molten fat keratic precipitates had disappeared, and the anterior chamber cells were also has disappeared. Thank you.
Okay, so Max, good case presentation. So you gave the diagnosis of granulomatous anterior uveitis, right?
Yes, ma'am.
So why don't you say it as non-granulomatous? What are the differentiating factors of granulomatous and non-granulomatous anterior uveitis?
Granulomatous uveitis, it is characterized by the formation of granulomas, which are clusters of immune cells that form in response to infection or inflammation. Whereas in non-granulomatous uveitis, characterized by absence of any granulomatous in the eye, granulomas in the eye. Also, in granulomatous uveitis, there will be granulomatous KPs, which are large, yellowish, greasy, mashed potato appearance. And on histopath, we can see epithelial and giant cell. Whereas in non-granulomatous, it is small. They are small to medium, circular, white, and on histopath, we can see mononuclear phagocytes. And granulomatous uveitis tends to have be more chronic and indolent course as compared to non-granulomatous.
Okay, fine. So what are your differentials of granulomatous anterior uveitis? What disease can you give?
In our country, most common is the tuberculosis, followed by because the chest also involved, the sarcoidosis can be there, then leprosy, syphilis, then they can be also Vogt-Koyanagi-Harada disease, in which you get bilateral granulomatous uveitis, and they can be sympathetic ophthalmitis also.
Okay, good. So which investigations would you like to do and go ahead with these kinds of patients? Most specific investigation.
First, we'll see on examination, visual acuity, intraocular pressure, slit-line examination, and on dilated fundus examination. Followed by we do a blood count, complete blood count to rule out infection and inflammation. Then we do ESR, C-reactive protein. These are prognostic marker for inflammation. Then we do quantiferon TP or Montux test and HRCT chest. If patient is not affordable, we can do chest X-ray. And for doing HRCT, we do serum create prerequisite for doing HRCT chest.
Okay, so now this patient was already diagnosed as sputum positive, right?
Yes.
So we've started him on AKT, you said, right?
Yes.
And he's diagnosed as tuberculosis. So what other posterior segment manifestations can you see in cases of ocular tuberculosis?
We can see choroiditis, which can be serpiginous like choroiditis, which have yellowish white lesions. Then there can be also retinal vasculitis, which are vascular sheathing, leakage or occlusion. There can be choroidal tuberculomas, and there can be also end ophthalmitis can be present in this patient.
Okay, fine. Any idea about COT studies? Do you know anything about it?
It is a COT study. It is a collaborative ocular tuberculosis study, and it was aimed at collecting data regarding ocular tuberculosis, the diagnosis, and how to approach for the treatment. It's a multi-centric collaborative study done across various countries in the world, collecting data about ocular tuberculosis, and it has a diagnostic criteria depend on the clinical features, symptoms of anterior posterior uveitis, imaging findings, fundus photo, fluorescent angiography, then indocyanine green, then depend on the lab investigation, tuberculin skin test, then interferon gamma radioimmunoassay, chest X-ray, sputum analysis, and it's also depends on the treatment protocol. Like there are different treatment protocols like antitubercular medications, corticosteroids, or any other immunomodulatory therapies like mycophenolate, azathioprine, cyclosporine, and most it's a long-term follow-up, it's a 10-year study to find out to assess the treatment response, the disease recurrence, long-term outcome, and related to visual acuity and ocular complications. And also it is an educational initiative to raise awareness among healthcare providers to diagnose and manage ocular tuberculosis.
Okay, good. So you know quite a lot about COTS, I think. Okay, good, nice. Sir, you can
I would
go ahead.
thank you, Prajakta ma'am, and thank you, Dr. Maxwell, for a wonderful case presentation. Basu sir and Mayur sir, any suggestions and tips for all of us? How would you like to approach the case presented by Dr. Maxwell?
Rohit, with your permission, I'm kind of itching to comment on this one.
Yeah.
I need the slide for that. Can you put back the slides, please?
Yes, sir.
Just go to the vision.
Yes, sir.
Anyways, you remember what was the visual acuity of the patient, right?
Yes, sir.
Yeah.
So can you see?
Yeah. So counting finger 1 meter in the right eye and close to face in the left eye. Now show us how much is the cataract. Where is the next slide? You said nuclear sclerosis grade 2, right? No, you also mentioned there. Yeah.
Yeah.
Nuclear sclerosis grade 2, right? And iris pigment on lens. Now the final part is the fundus. So you said fundus looked all normal, right? The next slide. So where do you think was the vision lost? The NS2 cataract will not cause CF 1 meter and CF, right?
Yes.
You agree?
Yes.
And you're saying the vision, the fundus is normal. Actually, you had a different thank you slide which Sumit shared with me earlier. Do you have that slide with you which had a retro illumination picture?
No, sir.
There's another thank you slide which was there of the right eye. You know,
yeah, that is.
Sumit, you remember? Do you have it? Can you pull it out because that's very, very critical.
I will do that.
Yeah.
So till you can continue to discuss. I will just put PPT on in 2 minutes.
The answer to that vision, I mean, that will strike you, right? Such low vision with hardly any cataract. People have 20/20 vision with, nuclear sclerosis grade 2. So where is the vision being lost? And this is not about, uveitis or this case per se. This is about our approach to ophthalmology in general. So I think there's a big lesson for all of us to learn here, and don't be too shy about this, because all of us have made this kind of mistakes. So let's see what we can learn here. Can you share the slide now, Sumit?
Sharing, sir.
Just the thank you slide which you shared with me.
Yes, sir.
Yeah, there is the answer to your poor vision. What do you see in the glow?
Vitreous is.
No. What is that glow looking like? Is that a normal fundus glow? Don't you think it's too bright? Anyone else has an answer to that? Yeah. No, that. Thank you, one. Yeah.
Yes.
And anyone else has an answer to this? What kind of glow is this which you see in the background? One thing you are sure, right? The cataract can't cause CFCF. And you didn't tell us what happened after the treatment with anti-TB therapy. What happened to the vision?
So vision.
I don't think the vision improved with anti-TB therapy either. Okay, because what we are seeing here is a sunset glow, which is characteristic of chronic Vogt-Koyanagi-Harada disease. Okay, and that is the reason why the patient had the vision that you mentioned for this in this case. Okay, so this is a classic presentation of the chronic recurrent phase of VKH. Now you will argue that the patient had a sputum which tested for positive for the gene expert. Now gene expert, when you look at the test report, you have to look at it carefully. Many of the reports of gene expert will tell you that it is mildly positive or it is borderline. I'm forgetting the exact terms for it, but we should not trust our diagnosis on the gene expert report alone. The diagnosis of ocular tuberculosis should depend on what you are seeing inside the eye. And in this case, what you are seeing inside the eye is definitely not TB. What you are seeing here is granulomatous panuveitis associated with chronic Vogt-Koyanagi-Harada disease. And that is what explains the vision of this patient. Mayur, would you agree with me?
See, there is throughout the entire presentation, there was one thing that I was thinking, and that is that whenever I see a patient of uveitis who I think is going to be tuberculosis or not going to be tuberculosis, one question that definitely strikes me is, if this is tuberculosis, is this multibacillary or is this possibacillary? Now, in a very simplistic way, if I were to put it for the entire audience, when one is talking of pure, isolated ocular tuberculosis sort of scenario, where a chest CT would have some lymph nodes, old cocks, one is talking of possibacillary. And when one talks about sputum or anything like that being positive, then one thinks of a sort of a multibacillary scenario. Now, this fundus picture, definitely the way that entire thing is, even if I were to feel that there is some intraocular tuberculosis, then I would think of large choroidal granulomas or some such sort of a picture with that glow. That glow to me looks almost, sort of orangish, yellowish sort of glow. Yes, so that is a very relevant point made by Basu. Very relevant point.
So, I'll just emphasize again that this is not just about diagnosing VKH in this patient. This is also about thinking, when you're seeing the patient, thinking logically and trying to explain what is there in front of you. Okay? You have such a poor vision and hardly any cataract, then what is the cause of this poor vision? And that itself would have led you to the diagnosis. Okay?
There is one thing that probably I would have done a little differently is that in the very beginning, before making the diagnosis, I would have probably done a USGB scan because I have this, sort of, you may call it a penchant of doing USGB scans to see how the peripapillary choroid is in all patients in whom I am not able to see the fundus very clearly. So I think that is one thing that I would have probably done differently in this case. Having said that, there is one thing that I would appreciate about this entire case and the presentation that Maxwell did is when Prajakta ma'am was asking him the differentials of granulomatous uveitis, he went straight 1, 2, 3, 4, 5, 6, 7, 8, and he included VKH in that. He said that when one has this, and he also included sympathetic ophthalmia. So we've been examiners in DNB many times when such cases are there, and when we ask differentials, then the student goes, and then you have to really coax and cajole them to get the differentials. But Maxwell, I think really nice that you gave that entire list very fast and very quickly. So that's one thing that I liked about that presentation.
Sir, coming back to the discussion, in terms of VKH, should we start with immunosuppressants at day 1 once the diagnosis is made? And how long should we continue the immunosuppressants? And which is the drug of choice in your practice?
Yeah. So in this case, where I would make, I'm jumping the gun a little bit because I've really not seen the fundus. I'm just talking from the sunset glow that I could make out on that slide. But let's assume that I reach the diagnosis of chronic recurrent leakage in this patient. I would start, and who has been untreated so far with corticosteroids, I would start very aggressively with corticosteroid therapy. This is one place where I don't taper, I don't give that 1 weekly taper. So my max dose of corticosteroid is usually 60 milligrams per day, but I would keep the 60 for at least 3 weeks. Okay? And then taper depending on the response, because these people need a lot of steroids. And it's also very important to counsel the patient about the need for these steroids and the potentially blinding nature of leakage. So, and then also taper slowly depending on how the response is. The immunosuppression, I start right on day 1. Even when I'm those cases where I give IVMP, I start right on day 1 because the immunosuppression takes at least 2 to 3 months to kick in. And if you don't start on time, then by the time your steroids are tapered, you won't have the effect of immunosuppression working in. So my drug of choice is always methotrexate. The only cases where I do not give methotrexate and prefer azathioprine instead are young females who are potentially going to be mothers. So this is one group where azathioprine is safe for pregnancy as well as lactation, and therefore I always choose azathioprine in that group. Now, in terms of efficacy, mycophenolate and methotrexate are nearly close by, but azathioprine is actually having a little lower efficacy than both of these. And also, I see that at least in my patients, azathioprine has a higher risk of blood counts going low or the liver enzymes going bad. And therefore, I'm not a big fan of azathioprine, but not to say that it's a bad drug. I have very good friends who have been using azathioprine routinely in their practice, and their patients have been doing well. But my choice is methotrexate. The last question is how long? And the answer is really, how old you are. Because the earlier in your practice, you tend to give your immunosuppression for a year. Then as you start gaining more experience, you find that a year is too less. And then you start giving it 2 years. And then when you're really old, you realize that even 2 years is too less. VKH, really speaking, if you ask to very senior people, say Professor Amod Gupta, Dr. Narsingh Rao, etc., you will find them telling you that VKH, once a disease, always a disease. I have had a patient who had a recurrence after 8 years of quiescence and followed up every year. And despite that, had a recurrence after 8 years of quiescence. So really speaking, once a disease, always a disease. And there is no limit to which you can give the, but usually I give for at least 2 to 3 years in most of my patients.
So as far as the duration of the immunosuppression is concerned, I agree with Dr. Basu. VKH, there have been patients whom I have immunomodulated for about 4 to 5 years, have had about 3 years of quiescence. So the last 3 out of that 5 is a quiescent phase, then stopped, then had a duration of about 2 to 3 years of remission of treatment, and then a relapse again. And, you need to restart this thing. So, like he's saying, the more you are in practice, the more you realize that VKH is one disease where probably you are going to have durations off and on treatment, and the durations on treatment are really going to be large. While the patient is on treatment in VKH, one should have an almost zero tolerance for even anterior uveitis. So if the patient is on immunomodulation and you are having some, minimal attacks of anterior segment inflammation, that means the patient is not immunomodulated completely. And you need to probably step up the immunomodulation so that even those anterior relapses don't occur. I agree with Dr. Basu that methotrexate is probably quite an underrated drug. I think it works very well. I've had patients even of VKH who are on methotrexate and doing quite well. The initial teaching used to be that azathioprine is the better drug for VKH, so more patients are on azathioprine. But those few who are on methotrexate are doing as well.
Thank you, Mayur sir. My last question for the day is for Basu sir and also for Mayur sir is how should we incorporate COTS suggestions in our clinical practice? The consensus which was developed amongst experts, how can we incorporate an
I
approach?
think Basu, you should take that question.
Sorry, Rohit, my AirPods.
So the suggestions, the consensus which was published by the COTS group, how should we incorporate in the practice?
Yeah, I think firstly, COTS is a great effort because it's not easy to get 70, 80 experts from so many different countries under a single umbrella. So it must be lauded for the intention that it had. But that said, as of now, and this is entirely a personal opinion, the current COTS guidelines, if you look at it from the biology of Mycobacterium tuberculosis or from the perspective of ocular inflammation, I think they need to evolve a lot more. A simple example is the kind of weightage it gives to one test versus two tests being positive. For example, if only MON2 is positive, you have so much of weightage. If both MON2 quantiferon are positive, you have more weightage. I think these things don't really agree with the immunology of mycobacterial infection per se. So these things will need to evolve. What I would want to see, and this is something that only COTS can do because it has that kind of a handle, it can that kind of a reach to so many places, is to learn from pediatric tuberculosis. I think that is where we need to look at. And if you look at the literature of pediatric tuberculosis, it is kind of a scoring system. Many of us think that only ocular TB is something where we do not have evidence of mycobacteria and we still keep on treating with ATT. But if you look at most extrapulmonary tuberculosis, from the CNS to the skin to the GI tract, actually most of those people, in majority of their cases, at least more than 50% of their cases, they never get any evidence of, microbiological evidence of mycobacterial infection. And they still treat and nobody tells them a thing. Only when ophthalmologists ask for ATT, people have a problem. So where we need to learn from is pediatric tuberculosis and the way they have developed a scoring system by which different things give you a score, and these scores add up and take you to a diagnosis. Now, for example, given a chance, I would want a score for a recent TB contact. I would want a score for the clinical phenotype that you're seeing in the patient. For example, a patient coming with only non-granulomatous anterior uveitis, even if both the tests are positive, should have no importance. So that will have a very low scoring. Whereas a patient coming with serpiginous-like choroiditis will have a very high score. So the clinical phenotype, the TB contact, uh, these kind of factors should add up and give you a score that will take you to a diagnosis. As far as I know, the COTS 2 is coming up very soon, and I'm sure they will incorporate these kind of approaches to modify the COTS criteria. Till then, I'm not buying the current criteria in its current form.
Right, sir.
There's just one thing that I would like to say about this entire thing. See, we have criteria for tuberculosis, we have for sarcoid, we have for Behçet's. But in a real world, when a patient is in front of you, hardly are these criteria in going on in your mind. You are seeing the patient, you are trying to make a diagnosis, you are trying to start the treatment. Next visit, you are actually trying to see whether what you have given has really worked for the patient or not, because there are so many of these other factors. I think most times in uveitis, the thing is that uveitis, I think, uh, is maybe the second only is retina. Probably uveitis is one of the most humbling sort of experiences treating a uveitis patient, because you are not only dealing with many times an organism, you are dealing with the immune system of the patient, and you are dealing with whatever treatment that you are going to do to modulate the organism and the immune system. And then there are three of these factors. There is the patient psyche, there are relatives. So criteria are hardly on your mind when you're treating a patient. It's just to get the diagnosis, to get the treatment in place.
Thank you, Basu sir and Mayur sir, for your insights. It was really, we all learned a lot on how to approach a case and how to understand key clinical features, how to correlate with the visual acuity, and then look at the differential diagnosis. So I myself could take, away key points, especially when you spoke about the retro glow and to correlate the visual acuity. It is so important in practice. And whether we are in any specialty of ophthalmology, to correlate the clinical finding with visual acuity is so important. Thank you, sir. Also, I would like to
Thank you very much. Yeah, Rohit.
Thank you.
Thank you, Prajakta ma'am, for being the mentor, Dr. Sumit for wonderful coordination, Dr. Maxwell and Dr. Shruti for wonderful case presentations, and all the office bearers of MOS for giving us the opportunity.
Thank you, Rohit, for coordinating and moderating the show so nicely. And of course, we have to thank our sponsors, Entode. So, Rahul sir, if you don't mind, can you just play the video for the Entode? Rahul sir? I think uveitis is the only place where we always have some dilemma, and it is the time that we disturb all the faculty. And thank you, Mayur sir and Basu sir, for making it so simple for us, and trying to catch even a simple picture from the PPT which was not shared, which was shared prior, and then understanding the whole diagnosis. It's marvelous. It shows your experience and the expertise in the field. Dr. Maxwell, Dr. Srushti, very well presented.
Thanks.
Yeah. So, I would really want to congratulate both the presenters, because it's not easy to come up on this kind of a forum and present your case. And they really worked hard on their case. It was showing very much. Thank you very much.
Thank you, sir.
Thank you, sir.
Basu sir, any suggestions for our PG programs generally?
The only suggestion is that I hope more PGs are watching this, because there are so many programs going on. I think, people tend to ignore some of these. So I hope more PGs are watching this and they gain from this kind of a discussion.
Yes, sir. Yes, Rahul, sir, go ahead. Thank you so much for that, and thank you everyone for their time and contribution to the webinar. Thank you all.
Thank
Bye.
you.
Good night.
Thank you. Good night.